Hello everyone. So I'll be solving a few doubts of general surgery which have been put up by the students. Now a lot of students had one common doubt, that what is the ideal treatment of a carbuncle or a caruncle. Now to understand that, you need to understand the basic difference between a boil or a furuncle and a carbuncle. So in this diagram here you can see the different layers of the skin. So we have the epidermis, the middle layer which is the dermis, and beneath that the subcutaneous tissue. Now we all know that our skin contains something known as hair follicles, and any infection which can occur in and around these hair follicles will cause these different conditions like the furuncle or a carbuncle. So any infection that originates in and around the hair follicle is essentially called as folliculitis. Now when we talk about the basic difference between a furuncle and carbuncle, you can see, so the first basic thing which can occur is a pimple, which is quite superficial. It is restricted mainly to the epidermis, and any infection of the hair follicle which is at the epidermis and has gone slightly deeper into the dermis will be called a boil or a furuncle. And a cluster of multiple boils which have involved multiple furuncles which have clustered together, and they are pretty deep and pus filled and usually caused by staph infection, that will be called a carbuncle. So a carbuncle is basically a cluster of multiple furuncles with pus. So two things to keep in mind, that it's a cluster of boils and it is a deeper infection. Since multiple furuncles have joined together, it has burrowed a little deeper into the skin, so it's much deeper than a furuncle. So the from superficial to deep, we have this pimple, the furuncle and the carbuncle. Now as you can see, furuncles in this diagram, it's pink or red bumps type appearance which are quite painful with inflamed erythematous skin around it. But when we talk about a carbuncle, since the severity is much more, there are you will see a severely inflamed tender nodular area surrounded by erythematous and tender skin. And also along with that, you will see multiple sinus tracts in which there is pus coming out, easily and freely draining pus. Along with this, because of this staph infection, the patient will also have generalized symptoms like high fever, there will be regional lymphadenopathy, malaise, the patient will feel weak and exhausted. So definitely the symptoms are much more severe. And of course a furuncle might burst and it might heal without a scar, but when we talk about a carbuncle, it will have it will usually take a longer time to heal and it can leave a scar. So when we talk about the diagnosis, definitely the first thing we should do is we should take a sample of the pus and send it for sensitivity, culture and sensitivity, and that will give us an idea as to what antibiotics have to be given. Given that it's usually a staph infection, it's very important to start off with the antibiotics empirically first, and then once your report comes, you can change to the more specific antibiotics. Now but that is not the ideal treatment. A carbuncle being such a severe and deep infection of multiple hair follicles, the ideal treatment is incision and drainage. So that is done by first infiltrating local anesthesia around the lesion, not directly into the lesion. Be careful about that. Once that is done, of course, the pus will freely start flowing out. So apply pressure and let the pus drain out. We can insert what you can see here, a sinus forceps, and open it up and break down all the locules of the pus. Allow all the pus to drain. Irrigate the area well with saline and betadine. And then once you've done that, you should loosely pack it with iodoform gauze, which will help in keeping that site open, because otherwise it might collapse and not allow the further pus to drain. So loosely pack that area, and then of course you have to continue with the antibiotics orally for at least a week after the surgery. So that is the ideal treatment, incision and drainage. Now a lot of patients have a tendency to develop these carbuncles, so some preventative measures can be taken. They can use a benzoyl peroxide wash. They can make sure to use antibacterial soap, and also they can apply a topical mupirocin or a tea-backed ointment as well. This can also be done after the incision and drainage procedure. So the ideal treatment is incision and drainage. Now the next question is, what is keratoacanthoma and is it a pre-malignant lesion? Now keratoacanthoma, as the name suggests, you can see it's a low-grade tumor originating, as you can see on the skin. So it's originating from the sebaceous glands, and it's said to closely resemble squamous cell carcinoma. Now when you look at the keratoacanthoma, You can see that it's a dome shaped lesion around 1 to 2 centimeters, and you can see the central portion has a punctum or a kind of a which is filled with keratin. So a keratin punctum can be seen in that, and or a keratinous plug. Now when we talk about this keratoacanthoma, there are two characteristics. One is that it initially has a very rapid growth over a few weeks, but once it reaches a certain size, it's kind of self-limiting in that it does not keep on infiltrating or growing, and over 4 to 6 months it resolves spontaneously. So that is one important thing. Initially it grows very fast, but it is self-limiting and it will stop growing by itself. So that is something to keep in mind, because unlike squamous cell carcinoma, this is self-limiting. Now, this usually occurs in sun-exposed areas due to exposure to UV radiation, any chemicals, or some patients might have a genetic predisposition to it as well. Now, the only reason why the confusion or the arguments about whether it is like a squamous cell carcinoma is that when you take a sample and check for it histologically, you will see some abnormal keratinocytes and keratin plugs, which are quite characteristically seen in a squamous cell carcinoma histology as well. So that is one reason why it was initially believed to be a squamous cell carcinoma. However, due to its clinical behavior, it's quite benign in its clinical behavior. Only microscopically there are some dysplastic features. So due to this difference, it's usually called as clinically benign and microscopically malignant, and a few studies have been done now. So remember this: clinically benign and microscopically malignant. A lot of research and studies have been done on it. It keeps on getting reclassified from benign to malignant, but now it is believed that there are some variants of this condition which can later on transform into a squamous cell carcinoma. So that's why it now comes under the grouping, as you can see here, it comes under the grouping of a pre-malignant lesion. So yes, to answer your question, it is considered now to be a pre-malignant lesion. Now coming to the next question, what is the relation between folic acid deficiency and pernicious anemia? Now do not get confused in these two conditions. Pernicious anemia is related to B12 deficiency, not folic acid. So you know that anemia can be either microcytic or macrocytic. Macrocytic meaning that the red blood cells are larger than normal, so they are basically larger in size, and they can be classified into two types. So macrocytic has the megaloblastic anemia. It is a type of macrocytic anemia. So in this we'll have increased MCV in both, and you can see that in the megaloblastic type, they'll have characteristic cells which are immature RBCs with hypersegmented neutrophils and containing a nucleus. A mature RBC should not contain a nucleus. So these are immature RBCs or megaloblasts. In this type of anemia, there are two types, either due to B12 deficiency, which is pernicious anemia, and due to folate deficiency. Now, similarly, we have the non-megaloblastic type, which can be due to any systemic conditions or alcohol intake. When we talk about megaloblastic anemia, which is a type of anemia containing these abnormal megaloblasts, it can, like I said, due to vitamin B12 deficiency. Now, even in that, it can either be because the patient has not been taking it in, for example, as seen in vegetarians, due to poor dietary intake, they might develop this B12 deficiency. It can be due to any surgical procedures which were done on the patient, or due to certain syndromes like the Zollinger-Ellison syndrome, or any other conditions wherein the absorption has been affected. Similarly, due to any autoimmune conditions or proper malabsorption, that is a type of anemia called as pernicious anemia. So pernicious anemia is a macrocytic megaloblastic anemia caused due to B12 deficiency or malabsorption. Similarly, we have the folate deficiency anemia also, but that is not pernicious anemia. That also can either be due to poor intake due to malabsorption, increased demand in a pregnant woman or in a child. The demand for it is more, but they are not taking as much as the body needs. So due to that, or due to malabsorption or anti-folate drugs. So that's a totally different type of anemia. They both come under megaloblastic, but it's not connected to pernicious anemia. So what happens in pernicious anemia? There's something known as the intrinsic factor of Castle, which is a glycoprotein. It's produced by the parietal cells of the stomach, or the gastric parietal cells. Now what happens in pernicious anemia is that there is destruction of the parietal cells. So it's an autoimmune condition. So there are autoantibodies which are formed against the parietal cells. Due to destruction of these parietal cells, they are unable to form the intrinsic factor, and intrinsic factor of Castle is very, very important to absorb the vitamin B12 into the bloodstream. Without that, the B12 absorption cannot occur. So even if you are taking sufficient B12 through your diet or other sources, that B12 is unable to get absorbed and actually carry out its functions. So due to inability to absorb this B12, there will be insufficient creation of healthy red blood cells. B12 again is very important for the DNA synthesis, which is important in the formation of red blood cells. So due to that, it causes this anemia known as pernicious anemia. So the relation with pernicious anemia is not with folic acid, it's with vitamin B12. But yes, both the vitamin deficiencies will cause megaloblastic anemia. Now the next question is, if a thyroid nodule shows increased radioisotope uptake, the investigation of choice is. Now first understand the question. What does it mean by increased radioisotope uptake? Now there's something known as the thyroid scan or the thyroid scintigraphy. In this, what is done is there's a radioactive tracer, either iodine 123 or 131 or technetium. So 99 technetium. These are two tracers which are basically, it's a protein. It is attached to a radioactive material, and this is administered to the patient either orally or intravenously. Now what happens is that when this tracer is administered to the patient, it will be taken up by the thyroid gland, and the uptake of this tracer by the thyroid gland will give us a clue as to if your thyroid is hyperfunctioning or hypofunctioning, or if there's any abnormality in the gland. So how is that done? So you can see this is how a normal thyroid gland should look like, that the radioisotope uptake here is normal. Now sometimes the uptake might be less or the uptake might be more. So as you can see here, if the tracer uptake is greater than the surrounding thyroid, so here you can see in this particular area, this area has a higher radioisotope uptake. You can see here in the hot, it's called a hot nodule. That is, this area is taking up more of the tracer than the rest of the thyroid. So what does that mean? That this thyroid is hyperfunctioning. So either the patient might be suffering from hyperthyroidism or Graves' disease. So there could be many things. So goiter, iodine deficiency, Graves' disease. So there could be, so these conditions are usually will cause something called the hot nodule. Similarly, you can have something known as warm nodule, wherein the tracer uptake is equal to that of the surrounding thyroid, that is, it's evenly taken up. Whereas you can have a non-functioning or a cold spot, that would indicate that the uptake is lesser than the remainder of the surrounding thyroid. So it could indicate less or hypofunctioning or a hypothyroidism. Now these three possibilities also give us a clue about the possibility of the patient having cancer. So usually if you see a cold spot or a cold nodule or a cold uptake, it could indicate that there's a higher chance of it being a malignant growth. So that is called as the cold spot. Similarly, the hot nodule would indicate that the chances of malignancy are lesser. So keep that in mind, the three types: hot, warm and cold. Hot indicates a hyper-functioning thyroid gland or hyperthyroidism, but less chances of malignancy, whereas a cold spot would indicate that low function of thyroid but chances of malignancy. Now once in the question you can see if there's increased uptake, that means a hot nodule. So that could indicate a hyper-functioning thyroid gland, which is not, and this question itself is indicating thyroid scan, and they have asked the next investigation, so we can remove that. Now among these two, we all know that biopsy, and among biopsy and FNAC is considered to be the gold standard for any diagnosis of thyroid conditions, that is the best investigation of choice which is done. Whereas when we talk about biopsy, there is a chance of damage to multiple vital structures around the gland, the arteries, veins and nerves. So the next investigation of choice here would be FNAC. So both of these are the investigations of choice. So here this is a table which will show which will tell you that what investigations can be done. So as you can see here, if there's a nodule of more than 1 centimeter, scintigraphy, which I explained, is the investigation of choice, but you are not getting a very good clear-cut evidence of any autonomy, or you're not sure that what that indicates, the next best thing to do would be to get an FNAC, and that FNAC then will give us a clear-cut idea as to whether it's benign or malignant and the next treatment. The next question is, in treatment of papillary carcinomas of thyroid, radioiodine destroys the neoplastic cells predominantly by. Now, what is this radioiodine therapy? Now, any kind of thyroid diseases or thyroid cancers would require a combination of surgery along with radiotherapy. Now, this radioiodine therapy has been used for over 50 years for so many conditions like a hyperfunctioning thyroid gland, a toxic multinodular goiter. So it's very useful for treatment of hyperthyroidism as well as thyroid cancer. So in patients where thyroid surgery is contraindicated because of them being medically compromised or high risk of the tumor damaging the surrounding structures, there's high risk of surgery. In these conditions, this treatment is indicated, and it is popularly known as the unbloody thyroid surgery. So we are reducing the risk of very toxic or fatal bleeds which can occur during surgery. Now this therapy basically again acts in the same way as what I mentioned about the thyroid scan. So this will emit two types of rays, the gamma rays and the beta rays. The gamma rays are generally used in what I spoke about in the thyroid scintigraphy for uptake to check for the hot and cold nodules, and the beta rays which they emit are used for treatment purposes. So how does this iodine 131 act? So basically we all know that iodine which we take through our diet, it's going to enter using the sodium iodide pump into the thyroid follicular cells. So we utilize that same process wherein we attach the radioisotope with the iodine, allow it to enter into the thyroid follicular cells, and once it does that, it will emit these beta particles which will cause inflammation and fibrosis and damage the thyroid cells, and that thereby it's going to damage the neoplastic cells. So how does the radioiodine destroy the cells? It's mainly by the beta rays, whereas the gamma rays are used for diagnostic purposes. Okay, the next question is treatment of choice for SIADH. Now, SIADH is syndrome of inappropriate ADH. Now, what is this ADH? ADH is basically the antidiuretic hormone, also known as vasopressin. Now, this hormone we all know, it acts on the nephron of the kidney, and it has two main functions. The first one is the water reabsorption. As you can see here, there are certain channels it will open which are known as aquaporins, and by opening up of these channels, it will help in reabsorption of water. And keep in mind, only reabsorption of water, not sodium, but reabsorption of the water, so that the urine will be more concentrated. So it's basically our body's way of conserving water. So at the level of the collecting tubules, the water gets reabsorbed by this antidiuretic hormone. So it's going against diuresis, so it's called the antidiuretic hormone. The next function is it constricts the arterioles and causes increase in the blood pressure. So these are two important functions. So its main aim is to conserve water and prevent excessive water loss. However, if there's excessive production of this, what would happen? All of the water will get built up or overloaded in the body, and there would be extremely concentrated urine that comes out. Now, too much of water is also not good. It will cause volume overload, and volume overload in turn puts pressure on our other organs, especially our heart and brain. So in this syndrome, you can see there's excessive ADH secretion and hyponatremia. By hyponatremia, now don't get confused. So if there's excessive water reabsorbed and we have too much water in our body, but because of this excess water, this relative sodium will appear to be less, because that sodium was only supposed to be there for a certain amount of water. But since the water is more, in the end it will cause dilutional hyponatremia due to excessive water. So there will be hyponatremia, hypervolemia. Now what happens? Like I said, the excessive reabsorption of water will cause the decreased urine volume and extremely concentrated urine, and it will cause nausea, vomiting, brain swelling, respiratory arrest, coma. So all of these signs and symptoms because of excessive volume overload and excessive increase in blood pressure. So when we talk about the treatment of SIADH, the treatment of choice, so there are two drugs which can be popularly used. We have lithium carbonate and demeclocycline. Among these two, demeclocycline is the treatment of choice. So demeclocycline is a tetracycline antibiotic. If you remember, it comes under the class of tetracyclines, and these drugs, they act on the collecting tubules, and they will this mechanism of opening up these aquaporins will get blocked by these two drugs, and due to which it will prevent the excessive reabsorption and allow for the water to get excreted. So this reabsorption process gets blocked and it will allow the excretion of water. But both these drugs are nephrotoxic, if you remember. Aminoglycoside antibiotics are nephrotoxic. Along with that, they can also cause photosensitivity. But compared to the two, demeclocycline is slightly safer because lithium has a lot of neuropsychiatric side effects. The patient can get addicted to it. So due to that, among these two, demeclocycline is preferred. So this is the treatment of choice for SIADH. Now coming to the next question. The first line of treatment for a cavernous hemangioma is. Now, hemangioma is basically a collection of abnormal blood vessels or a malformation due to endothelial dysmorphogenesis. So, abnormality in the size and shape of the endothelial cells due to any cause. It can be genetic, it can be iatrogenic. There can be many causes of this hemangioma formation or a malformation. So when we talk about a cavernous hemangioma, it is nothing but a venous malformation. Now, when we talk about arterial versus venous malformations are relatively slow flowing blood, whereas arterial malformations are much more dangerous because the blood flows very fast through the arteries and there's a very severe and high risk of fatal bleeds which can even kill the patient. So compared to those two, cavernous hemangioma is not as severe as an arterial hemangioma or an AVM, what we call an arteriovenous malformation. Now, this usually occurs, it's known as a sporadic hemangioma. It can occur without any known cause all of a sudden. Some cases might have a genetic component as well. Now, when we talk about treatments for these hemangiomas, the main aim of our treatment is that we want to reduce the blood flow, because a hemangioma will have multiple feeder vessels. If this is the hemangioma, it will have multiple feeder vessels which are supplying it. So the main aim is that we want to reduce these or take away these feeder vessels or cut off the blood supply to that lesion. So this lesion or this hemangioma mainly survives on the blood supply. So if we cut off the feeder vessels, it will allow us to do a surgery better. So excision, yes, it has to be done, but normally as a first line, what we do is we inject a sclerosing agent. So we inject something known as a sclerosing agent like sodium moreuate, tetradecyl sulfate, hypertonic saline. So these things, what they do is they will cause fibrosis and inflammation and fibrosis, and what it does, it will cause collapse of these feeders, and if the blood supply of this lesion is cut off, the lesion eventually just collapses and becomes smaller in size, and these veins get scarred and it will collapse all these abnormal feeder vessels. So that is basically what sclerotherapy is. So injection with a sclerosing agent or sclerotherapy is basically the first line of treatment for such hemangiomas. Once that is done, once the lesion collapses, it can then easily be excised without much bleeding risk. Along with that, we can also inject corticosteroids or bleomycin. We can also give systemic corticosteroids as well. However, you know that they come with their own side effects. That's why normally, since the venous malformations are superficial, Veins are much more superficial compared to arteries. That's the reason why we always give IV. We don't give intra-arterial injections. So venous malformations, the first line of treatment, like I said, is sclerotherapy. Once the injections of the sclerosing agents are done, it will collapse the lesion, it will reduce its size, it will reduce the blood supply, and then after that excision can be done if required, and that will be much safer because the bleeding risk will be minimal. So normally up to 70 to 80% of them respond very well to sclerotherapy. So the correct option is C, that is injections. Now the next question is, thyroxine can be given in which kind of cancer? Of thyroid cancer. Now in thyroid cancer there are many types. We have the differentiated, which are again of three types: the follicular, papillary and Hürthl cell. Then we have the undifferentiated or anaplastic and the medullary. So the anaplastic kind of cancers usually do not have a good prognosis, whereas the differentiated, the three types, have a better prognosis, and there's much higher life expectancy. And now these in these kinds of thyroid cancers called as differentiated thyroid cancers, this thyroxine therapy is given. So to answer the question here, it would obviously be the papillary kind. Now why is this thyroxine given? For any kind of cancer, like I said, we have to do a surgical resection, and along with that we have to take out all or most of that organ. So normally a total thyroidectomy or a subtotal thyroidectomy is done, followed by the RAI, which I spoke about, the radioactive iodine therapy. And along with that, it's very important to administer thyroxine, because obviously if we are removing the entirety of the thyroid gland, there's a high chance of the patient developing severe hypothyroidism. So to maintain the patients at a euthyroid state and make sure that they have the normal levels, they will mostly need this L-thyroxine therapy throughout their life. So thyroid hormone replacement therapy is very important, since we are going to remove the totality of the thyroid gland. So this is a very important thing to keep in mind. And in which type of cancer? It can be given in the papillary as well as the follicular, that is the differentiated thyroid cancers. Now the next question is a clinical condition. So a 30-year-old female patient presented with complaints of palpitations and feeling febrile all the time with midline neck swelling. On examination, a diffusely enlarged thyroid is felt and lower border moves with deglutition along with exophthalmos. Now, looking at the complaints, which is palpitations, that is increased heart rate or tachycardia, feeling febrile, that is a high temperature, a midline neck swelling which moves with deglutition, definitely is a thyroid swelling, and exophthalmos. So there are 4 conditions here which all fulfill the criteria of something known as a thyroid storm. So this is nothing but a thyroid storm which occurs due to excessively increased levels of thyroid hormones. So the patient will normally have severe restlessness, delirium, psychosis. They'll have tachycardia with very severe high-grade fever. Along with that, pulmonary edema, rales, and there might be hepatic manifestations like nausea, vomiting and diarrhea, and one more would be exophthalmos as well. So if either of these criteria are fulfilled with at least one CNS manifestation plus one or more other symptoms, or a combination of at least 3 features, it would be fulfilling the criteria for a thyrotoxicosis or a thyroid storm. So this condition here is a thyroid storm or thyrotoxicosis. Now one more thing I just want to mention is that yes, FNAC is today widely considered to be the gold standard of diagnosing any lesions on the thyroid, but we have to keep in mind that we have to be very careful in case of a patient who has a risk of bleeding due to any either hemophiliac or a patient having the von Willebrand's disease or any kind of condition affecting his coagulation pathway. We have to be very careful and maybe avoid FNAC in those cases. And if a patient is suffering from hyperthyroidism, always get a blood profile first before doing an FNAC, and only do an FNAC if absolutely necessary, because a hyperthyroid patient has a slightly larger risk during an FNAC. Now the next question and the last one is, hyperbaric oxygen can be used in all of the following except. Now we all know this HBO therapy is something done wherein a patient is placed into a large high pressure chamber. So the patient is made to lie down in this high pressure chamber, which usually is at a much higher pressure than normal, and this high pressure basically will force the air into the lungs. So I've explained in a very layman term here. So lungs can gather much more oxygen than would be possible, and increased partial pressure and increased oxygen tension is very good for wound healing. It causes neoangiogenesis, and it also causes proliferation of the stem cells, which will help in wound healing. So that's the main focus of hyperbaric oxygen. So it's usually done for 3 main conditions which are mentioned here: gas gangrene, decompression sickness, and carbon monoxide poisoning. So these are the 3 basic conditions where this therapy is used. So we can eliminate option D, that is necrotizing fasciitis. It can be used in that as well, but not as effective as it would be in the first 3. So that would be the answer. We can eliminate D and we can put that as the right option. However, there are certain contraindications to this therapy. For example, if there's a pneumothorax or a severe bronchospasm, along with that the patient is undergoing treatment of bleomycin or doxorubicin, in these conditions absolutely HBO therapy is contraindicated. And if the patient is suffering from cold rhinitis or has a history of epilepsy, it has to be done very, very carefully under controlled conditions.